most important, hair loss is alopecia. All the time when patients walk in the door, they say, my hair is falling out, but please don't tell me I have alopecia. And I always tell them, you have alopecia by the sheer fact that you told me you have hair loss. Don't worry about it. What really matters is it scarring or is it non-scarring? So we're going to talk primarily about non-scarring alopecia because that's going to be what you're mostly going to see. So androgenetic or female pattern, something called telogen effluvium, which we'll go into, and alopecia areata. And then on the scarring side, one that's actually fairly common and I see all the time, like in planopilaris or frontal fibrosing alopecia. You will see this when you start seeing it, you will recognize it, and it will just sort of help you set expectations with your patients as to whether or not they need to see derm and whether or not they're going to grow their hair back. So the hair cycle, this is actually kind of important. So how does our hair grow? So anagen is when your hair is growing. So normally that's 2 to 6 years. That sort of determines how long people's hair can get. We have different anagen lengths for our eyebrows and our eyelashes versus our scalp hair and our body hair. And typically on your scalp, 85 to 90% of your hairs are in this active anagen growing phase, and they're growing about 1/3 of a millimeter per day. So you're getting a little bit more hair. We know this because we have to trim our hair. After anagen completes, then your hair goes into this short resting phase called catagen, where not a whole lot happens. And then it goes into telogen, which is a shedding phase where it actually detaches from the roots and gets ready to shed. We also know that this happens because when we brush our hair, some hair comes out in the brush or comes out, when we're washing our hair. And typically about 10 to 15% of the hairs on your head are in telogen. And normally you shed between 50 and 150 hairs per day, depending on the person. And the last little thing, which is sort of hidden for me, but there's a part called exogen, which some people describe as a separate part of the hair follicle, which is when the new anagen hair starts growing, it comes in and it pushes the telogen hair out of the way. So that's when you actually feel the shed, is during this exogen phase, actually when anagen restarts and pushes your telogen hair out of the way. Dr. Logan, do you want me to do the case or you want to do the case? You tell me.
I can read the case because this is my patient who came in to see me. So she's a 33-year-old, has history of biliary atresia. She just got actually her second liver transplant, but it was a simultaneous liver kidney transplant 4 months ago. She feels great, but she's fatigued, and she just says her hair is just falling out in droves for the last few months. Her ponytail is getting thinner. She was someone who prided herself on her thick ponytail. Now it is quite a bit smaller. And so she is extremely frustrated because she views this as just like, she doesn't have her life as her own life right now. She's on all these medications. She's seeing doctors constantly now. She's like, now my favorite part about myself is falling off my head, and I absolutely hate that. And so I'm curious how you kind of approach a patient like this. She's convinced it's her tacrolimus. She's like, this is my tacrolimus. It wasn't happening before. I started tacrolimus when I got my transplant. Now that's it. So how do you approach this patient? Just starting really, really broad.
Okay, so starting broadly. So here's kind of where I would start with the patient. So is it shedding or thinning or both? So, and if it's both, which one is she primarily having? Sounds like she's shedding, right? So, and was it gradual or sudden? It sounds like fairly suddenly, shortly after her transplant, she started shedding. Was there a trigger? Yeah, we think there's probably a trigger. Are there scalp symptoms? Like, is she itching, burning? Is there tenderness? Is there a rash? No, she's totally fine. What's her family history look like? So really important. It seems like this is going to be really straightforward, right? Because this seems like it's probably going to be related to either her meds or her transplant. But there sometimes in patients who have female pattern hair loss, they'll have an initial sort of large shed. So could be important, maybe not. What does she take? And have there been any major changes? Obviously, there are going to be changes because she just had her transplant. Although I don't know how much things changed if she was having her second transplant, if she was already on tacrolimus, I don't know. And then we actually dive into the exam and we get up there and we look at her scalp and we say like, okay, do I see scarring? And I'll kind of explain to you as we go through like what you're looking for when you're looking for scarring. So we do a scalp examination. You do what's called a hair pull test, which again, I'll explain to you what this is. Where is this happening? Is it happening all over the scalp or is it just happening in focal areas? Do we see any signs of hyperandrogenism? So probably not in this case, but and then are there any lab abnormalities that we could correct? Okay. So we don't know for sure, because obviously I haven't seen this patient, but this sounds like it's a case of telogen effluvium, right? So it's a sudden onset, it's diffuse, non-scarring hair loss. So when you're looking for whether or not there's scarring or not, you're looking to see if you can still see the follicular osteo. So can you see the opening where the hair is supposed to be? And sometimes you'll just see shiny white scar. I use a dermatoscope, so I use 10x magnification in my clinic, but you can usually see this just with the naked eye. Like, are there still follicles there? And if they're not, well, then you're scarring. And patients with telogen effluvium, they describe like massive shedding, like it's coming out in clumps in the shower, like it's all over my bathroom floor. And sometimes they're a little itchy on their scalp, not always, but sometimes they're saying I'm a little bit itchy. And they have a positive hair pull test. So a positive hair pull, you take kind of like a chunk of hair like this and you just go like this and see if you can pull any hairs out of the scalp. They should just loosely detach. It varies, but most people would say like about 4 telogen hairs. If you pull 4 telogen hairs in that would be a positive hair pull test that like you probably shouldn't be losing that many hairs. There's also some stuff about whether or not you should wash or not wash before, but a lot of the studies now just say like, it doesn't really matter. Just look and see if you're pulling a lot of telogen hairs. And if you are, you can probably say that it's telogen effluvium. So telogen effluvium is the result of an insult. I always tell my patients, your body is really smart. And if it feels like it's in danger of not being okay, it's going to shut off the things that aren't important. And your hair is not important and your nails are not important. So about 2 to 3 months after the insult is when you're going to see TE. So for most of our patients now, weight loss, diet, nutritional deficiency. So everybody's on a GLP-1, right? Whether they tell you or not, they're on them. And so they're all losing their hair. Surgeries, very common cause, just the sheer surgery can do it. Massive blood loss, anemia, women who have heavy periods, any childbirth or loss of pregnancy, medications that they start or stop. So stopping certain birth control pills can actually lead to a shed. Starting other birth controls can lead to a massive shed. Don't forget their supplements because everybody's taking a lot of supplements. And then if you've been really sick, like you've been in the hospital, you've had COVID, or occasionally if you're really, really psychologically stressed, death of a spouse, I'll see this. So when this happens, that hair cycle that we talked about, up to 50% of the hairs on your head can shift into telogen at once. So you go from 10% to 50%, it's a noticeable difference. Occasionally you'll see a nail change. So usually when we look at scalps, we look at nails too, because sometimes you'll see where the nail sort of stopped growing and restarted growing as well. And it typically lasts about 6 to 12 months after the insult is fixed. So if it's just the surgery, okay, fine. If it's a patient who's had multiple surgeries, that it may last longer. Or if it's a patient who has anemia from having heavy periods, until you correct that anemia, you still then have to wait another 6 to 12 months after that. But it does self-resolve, and you prescribe patients, which is the hardest pill to swallow. They've tried a lot of things to halt telogen effluvium, Botox injections and Kinalog injections and all sorts of things, but there's really not very much success with making telogen effluvium stop. The problem is the problem happened 3 months ago. There's nothing I can do now for something that happened 3 months ago. So for your weight loss GLP-1 patients, just make sure they're getting adequate protein and getting adequate actual nutrition from like real food, because I've found that a lot of my patients on GLP-1s are still not eating like super nutritious diets. They're eating less of things, but it's not necessarily really nutritious. And so make sure that they're getting their nutrients in. It won't stop probably till they reach their goal weight. So this is a severe case of telogen effluvium. So it's just decreased density all over the place. Most of my pictures are from up to date. I tried to cite them where they were. And this is probably what you'll see a lot of, which is actually the regrowth phase. So it's often bitemporal and sort of occipital scalp. And you'll see this little fringe sign where they're starting to regrow. So these are the new hairs that have come in and pushed the old hairs out of the way. And this is actually a really great sign. So all my postpartum patients who come in with hair loss and they look like this, I'm like, hey, look, you're on your way. It's almost over. Just keep waiting. So
Brandon, question.
Go ahead.
Oh, I did. Sorry. I just wanted to get a little bit of a quick clarifying question on the hair pull test.
Yes.
I know what I'm doing. I've never done that. Is this just like, I mean, yours like literally like kind of running your finger? You asked me to do this, or you actually are running the fingers?
I run my fingers. So, because when I look, I get up and I actually divide their hair like this and I part and I look down to their scalp because I'm trying to see on their scalp what their scalp looks like. And so then at the end, then I just run my fingers through like this and see if I can pull any telogen hairs with my fingers.
Okay.
So
yeah, that's helpful because like I remember I had a patient with hair loss because I was Dr. Comfort's like resident. And I remember talking to him about this and be like, I did a hair pull test. Don't really know what I'm doing here, but like I have like it says on Up to Date, it's like get 50 hairs or something like that. It's like, God, I don't know, like a little pinch. Who knows?
And no one's really going to count it. And I usually go through various areas of the scalp and just see, and you're going to, it's pretty clear. I mean, I would say, yes, they're like all these like hard and fast numbers of like, if you get 4, then it's a positive Some people say 6, some people say 2. But if you're doing this and they've come in to see you and you've got 10 hairs on your fingers, they've got telogen going on. So, because that's, they're only supposed to lose 50 to 150 a day and you're getting 10 in a 2-minute exam. So there is a chronic variant of telogen effluvium. So I actually just saw a lady with this week. She has had telogen effluvium for 10 years. This is when labs become sort of important. So thyroid, again, common cause of hair loss. You just need to make sure that their thyroid is normalized. Iron deficiency is huge. Nobody checks a ferritin. So ferritin is the number that we're actually looking for. I don't really ever look at their TIBC or their percent SAT or anything like that. I check their ferritin because that's where our goal numbers are sort of set. And the goal is higher than normal. So often I see, actually I had one yesterday, her ferritin was 25 and her PCP told her, it's totally fine. And I was like, hey, but for me, I want your ferritin higher than that. So your goal is 40 to 70 and most people feel pretty comfortable around ferritin of 50. And in your menstruating females, it's sometimes really hard to keep their ferritin at 50 if they're having heavy periods. A vitamin D, and then just late breaking stuff in an article that came out in the September JAD, they talk about checking zinc levels. It's not something I've ever done. I actually ordered my first one on this hair loss patient this morning. But they said in a fair number of patients with alopecia, they have abnormal zinc, and zinc's a necessary component for hair growth. And so I know zinc plasma levels are sort of not very reliable, but it's something to think about. B12 or folate, I check in at-risk populations if they have a reason that they might not be absorbing that or if they have a dietary thing. If they look like they're a rheumatology patient, check an A and A. I don't just check them on everybody, but if they, have other things that look like they might be going on there. And then maybe androgens, if they have signs of hyperandrogenism, if they look like they're a PCOS patient. Then total testosterone is the thing you would check, and then plus or minus the hydroxyprogesterone if you thought of for like a non-classical congenital adrenal hyperplasia patient, probably not in your older patients, but maybe in some of your younger patients. I rarely check hormones. I can't remember the last time I checked hormones because almost all my patients are on hormonal contraception, and so they're not very reliable when you check them on hormonal contraception, so I don't. So meds, you brought that up. So here's a nice little list of medications that can induce telogen effluvium. So you said her tacrolimus, which I don't see on the list. I actually don't know off the top of my head if tacrolimus is a common cause of TE, but I would say in her, it's again, sort of a weight type of thing. One, you're not going to switch it right away. And if it's just post-surgical and the fact that she was probably pretty sick before she most recently got her transplant, it's going to take us 6 to 12 months to know if it's that tacrolimus and then maybe change going forward. So, okay. Any questions on that before we move on?
Is there a vitamin D that you're targeting, like a particular level, or is it?
This is normal range. And it's kind of controversial too, I will tell you, but, I mean, vitamin D, who knows what all it's good for, right? We know it's good for bones. But if it's low, I have seen patients regrow pretty nicely when they replete, and maybe it's just a sign of their overall nutritional status more than anything, but, it does help if they replete.
Okay. And then Dr. Harry wants to know if there's any particular goal from that article for zinc levels.
So I don't know, they didn't. They just said abnormal zinc levels. So they found that actually, and it comes up in the next case, I think, that 40% of patients had abnormal zinc, low zinc. So they repleted them. So that seems pretty high. So.
Yeah, agreed. And Dr. Stolte, and we've got a lot of questions coming now. So Dr. Stolte is wondering if a med is causing telogen effluvium, is it chronic?
Yes. So, and that's the other sort of counseling thing is that like, okay, you're on lithium for your antipsychotic and it's making your hair fall out. It's going to make your hair fall out unless we can stop your lithium. Oh, but you're really well controlled. Sorry, and that's the like crummy part about it. Oh, you need your beta blocker, like your beta blocker is doing it. So sometimes I work with you guys to try to say like, hey, is there anything else we can do? But I always try to set the expectation that like hair is cosmetic, although we love having hair, and your heart is really important. So I always tell the patient, the cardiologist wins every discussion with me in this. So.
Fair enough.
Question.
Yeah. And Dr. Ellerbeck kind of said the same thing. He's just like, what do we do if they're on these medications? I guess it's risk benefit in terms of getting them off of it if they think they can reasonably do it. So Dr. Woodward had a question. Do you want to jump on, Dr. Woodward?
Yeah, thanks. It's a lot to type. I don't know why I can't raise my hand. I swear I read an article or study sometime, and I really hope I didn't make it up, that combining retinol with minoxidil can improve. I don't know if it's like
penetration,
absorption
yeah.
or whatever,
You
but I
did.
see it on this list. So now I'm like, what?
So yeah, so tretinoin, which is what they usually use, is not so much of a problem, but systemic retinoids really cause significant hair loss. But you were probably the major prescribers of systemic retinoids, not you guys. But yes, there was something that came out that said for men in particular, once a day minoxidil plus tretinoin helped improve penetration. So some of the places that compound topical minoxidils will add a little bit of tretinoin to it. It does increase irritation quite a bit, and minoxidil in and of itself is pretty irritating. So sometimes that limits whether or not you can do it, but it takes it from BID dosing, if you choose to do that, to daily dosing.
So topical minoxidil combined with topical
Tretinoin.
tretinoin is
Mm.
good,
It's
but
good.
the stuff you
This is-
prescribe is bad for
is
hair.
bad.
I've got it. Okay,
Yep.
thank you.
All right.
Okay, I
Any
think we're
more?
good. Yeah.
Okay. All right. Next case.
So, also both real cases. So CB is a 43-year-old female. And by the way, she did end up having telogen effluvium. She's someone who saw a dermatologist. They said, this is clearly telogen effluvium from your recent transplant. And she's already starting to get, you know, like some resolution of that. She's starting to improve. So it's great without any treatment or anything like that. And I want to make sure at some point, like when we discuss minoxidil and telogen effluvium, I think that's a really nice point in terms of the counseling. And so, but I think we do a little bit later, which is just awesome. So CB is a 43-year-old female. She presents today for a return visit. She has no concerns and just wants refills of her sertraline and her buspirone. But when you start talking to her, you kind of realize that she has had some hair changes over the last year, as seen below. So I saw her in 2024. And then in 2025, I just noticed like considerable hair loss. And she didn't bring it up. I actually had to be like, hey, is this an issue for you? Is this something? And she was like, thank you for bringing it up. Like, I want to talk about this. And then I'm like her favorite person in the world now because we tried something and it worked. So, and then kind of like on the other side, there's a male patient, MA, 41-year-old male, presents to discuss a receding hairline that is starting. He notes that his dad was bald by 50 and he wants to avoid this at all costs. He's wondering what he can do to halt progression.
Okay. So how do we approach it? So these are the exact same questions we asked before, right? So I'm not going to go through them just for the sake of time, but exact same questions we asked before. One thing I would point out on our case is that she's on Buspar. So that's a common cause of telogen effluvium. So just sort of worth addressing in the timeline, like, hey, did it get worse when you started that? Have you noticed a change? So like, hey, maybe we need to look into that. But this is likely a case of pattern alopecia. The male is definitely a case of pattern alopecia. So pattern alopecia, androgenetic alopecia, whatever you want to call it. So it's diffuse. It's typically all over, although usually focus more on the crown, but it's not little focal patches and it's non-scarring. So these people can regrow and their hair follicles miniaturize. So they have big follicles, but they mostly have tiny follicles. So their hair follicles go from terminal hairs, which is what are on our head, to vellus hairs, which are what on the back of your hand. And they describe like, I don't know when it started. It's been going on for like 5 years or 15, and it's thinner all the time. And the prevalence increases with age. So 60% of white females are going to have this by the time they're 80. It's the lower prevalence in Black and Asian patients, but it happens in pretty much everyone to a certain degree. Women typically have preservation of their frontal hairline. So this will look pretty good, but right here, they're really, really thin. There's usually a family history somewhere. Sometimes it's an uncle and aunt, and it can be on mom's side, dad's side. That's a common misconception, and it can be men or women. So if dad was bald, you can still inherit that as a female, okay? There's some debate in the literature. I think it's kind of splitting hairs as to whether female pattern and male pattern are the same process. They're like trying to figure out how much 5-alpha reductase inhibitors really work. For this purpose, we're just going to call them the same thing because you really treat them the same way. And I think for you guys, that's going to be easiest. It's a diagnosis of exclusion. So you really have to make sure before you say someone has just female pattern or male pattern hair loss that they don't have a low ferritin and they don't have a vitamin D deficiency or anything like that. If nothing else, they're not going to regrow great hair until those nutritional things are corrected. Okay. So what do we do for pattern hair loss? So minoxidil, you can do it topically or orally, which we're going to talk about. Spironolactone in women, particularly women of childbearing age, which we'll talk about. 5-alpha reductase inhibitors, we use both finasteride and dutasteride. Hair transplant, platelet-rich plasma, some people are doing. We don't do that in our clinic here. It's cash, it's expensive, it's not realistic for most patients, and probably hasn't given us the sustained results that we really want to see for the prices that people are paying. It's about $3,000, and people are not getting sustained remissions from it. maybe exosomes, maybe red light therapy, maybe low-level light therapy, but all that stuff's really new and I would say not really tested yet. So we kind of stick to the old reliables in our clinic here. So minoxidil comes in both topical and oral formulations. So topical minoxidil, 5%. You can give it daily to BID for both men and women. It's FDA approved differently for women than men because they were worried about excess hair growth. I just give 5%, give them 5%. It's fine. They probably are only going to put it on once a day as women just because it can make your hair feel kind of gross. And so most women like to put it on at night before they go to bed so they can style their hair in the morning. And then oral minoxidil. So we dose it so it comes in 2.5 milligram tabs as the smallest tabs. And we give a quarter tab up to a whole tab a day. And we always start with the lowest dose and then work up as we need. So we think minoxidil works by increasing blood flow and prolonging anagen. We try to tell people don't use topical and oral at the same time, just because you are getting a little bit of systemic absorption from your topical and then plus your oral. I can't really tell you how much you're getting. And again, it only works as long as you're going to use it. The main side effect, we already talked about, scalp irritation. It's very difficult to use topical minoxidil on a large surface area, and women don't love topical minoxidil because they already have thin hair. They're trying to floof it and tease it and all these things, and it makes your hair heavy and stay down. Most common side effect is an initial shed. So it lasts about 1 to 3 months after you start the minoxidil. So really important to counsel your patients through this. When you start minoxidil, it is going to look like your hair is getting worse. You have to keep going because if you stop, then we have to restart that all over again. An interesting one for oral minoxidil, sometimes you can have worse hangover symptoms if you drink too much. And then it makes you grow hair everywhere. So topical minoxidil, anywhere it goes, it can make you grow hair. And then oral minoxidil, people will get hairy. Women will get more chin hair, they'll get more lip hair, and that's sometimes sort of a treatment limiting thing. And then weight gain from fluid. The most serious thing you really need to counsel your patients on an oral minoxidil is fluid retention. So peripheral edema I see somewhat commonly, but risk of pericardial or pleural effusion. There's a case report of someone taking 0.25 milligrams of minoxidil and getting that. They got diuresis in the hospital. They were fine, but it's a thing. And then heart attack. It's rare, but I had a patient who had a heart attack and her cardiologist told me I can't give her minoxidil anymore. So she just has to lose all the hair we regrew. So check with cardiology. You can combine with a little low dose spironolactone to give a little bit of diuresis so they don't have quite as much weight gain. And you can't use it during pregnancy. There's fetal minoxidil syndrome. So it's not something you want to give in pregnancy.
So do you mind if I jump in?
No, jump in.
I start a lot of minoxidil on people. And it feels really weird for me to say, oh yeah, you might notice the initial shed. Also, you can get some fluid around your heart. And then people are usually like, whoa, hold on.
Yes.
So like, how do you counsel people on that so that they're not just like, yeah, I don't want that. I'll lose my hair. I'm not getting fluid around my heart. Like, are you talking to people about specific numbers and incidents? And you're just saying this is a possibility?
I'm just saying this is a possibility. And I just always tell them, look, I've never seen this. So that always reassures them. And I say, it's just something you want to remember, because if you went into the hospital and you told them I can't breathe, you may not think about your hair loss medicines to tell them. And I don't know if it's patient selection, but usually by the time they get to me, they're pretty darn motivated. Like I could probably tell them it'd kill them and they'd be like, please, I'll look good in my coffin with hair. Like they're really motivated. So it most of the time doesn't talk people out of it. And most of the time when I check with cardiology, they're okay with it. And even in that patient who'd had previous MIs, they let me start it. But once she had another MI, they were like, sorry, no more. So, any more questions or we're good?
Is the hair loss with minoxidil more substantial with telogen effluvium if you're using it in that setting versus with pattern alopecia? Or is it kind of like the
No, meaning if you start a telogen effluvium patient on minoxidil, yeah. So that's, depending on where you are in your telogen pattern, that's sometimes where I don't bother starting minoxidil because it's going to make it worse in the short term. Yes, you'll get quicker regrowth, but a lot of times I just say like, hey, just wait. Because usually by the time I get to them, they've already had it for 3 or 4 months and we're on the downhill slide anyway. If I was getting them immediately post-op and we were trying to do some prevention, it would probably be worth a try. I know some derms have a very different approach and they'll put them on minoxidil anyway, but you know, I don't think there's a right or wrong answer there.
Okay. And then we have a couple of questions.
Okay.
So, this is the way that these go. And like,
no problem.
So like, it's a good that people like, there's so many questions. So Mickley Polsak asked, what dose of spironolactone do you use? Which I think you're going to get to Spiro in
I
more
am going to get to
detail.
Spiro, hopefully.
Yeah,
Yeah.
and you said 50 milligrams maybe for fluid retention associated with minoxidil. So Mickley, we'll get to that. And if we don't, post again and we'll make sure we touch on it. And then Dr. Woodward said, have you seen any negative impacts of using both topical and low dose oral? And I think she means using them together.
Not necessarily. I just think you're increasing your risk sort of unnecessarily. I always tell people, like, I'm already giving it to you systemically. Like, I can't tell you how much you're absorbing through your scalp, although particularly if you're going to combine it with a retinoid, you're going to increase your absorption quite a bit. And so it gives me less of an idea of what my dose is versus if I give you a pill, I can tell you exactly how much minoxidil you're getting. So I'd rather go up on your oral minoxidil than combine it with topical. So
that makes sense. And then I don't know if we talk about this later. I can't recall from the slides, but do we touch on Nutrafol?
we do touch on Nutrafol.
Okay, awesome. Because that's going to be, everyone's going to have that question.
It's very important to me actually to touch on that one. So
okay, perfect. And then Brandon, you had one.
Yeah, just asking about dose response. So like, should we expect on oral minoxidil, should we expect more regrowth with higher dose or?
yes.
Okay.
Yeah, you should. So, but you always start lowest because I always tell people you might get where you want to be. We usually give it 6 months on each dose. And if they're where they want to be, we stop. And then a lot of women, they're like, oh gosh, there's so much hair everywhere else. I'm good. We're stopping here. So it's kind of finding that balance between like, do I need to pluck my chin every single day? You know, and is that making sense for me? And sometimes they're higher and they actually want to go back because they're like, dude, the hair everywhere else is just getting a little extreme.
So you started the quarter tablet.
I started a quarter tab. They're usually on it for 6 months.
Doable.
Most of my women land at 1.25. Most of my men land at 2.5. But I have people on all the doses. So.
Okay.
5-alpha reductase inhibitors, maybe your patients tell you more than mine do, but be aware that they're getting it from hims or hers online and they're not telling you. So, and no one at those online places is telling them the side effects either, because they come in and they're like, oh, by the way, I'm on this. And I'm like, well, did they tell you about prostate cancer? Did they tell you? No, they just asked me if I wanted it and they gave it to me. So just be aware it's out there. It's kind of the Wild West. Finasteride is FDA approved to treat male pattern hair loss at 1 milligrams by reducing DHT levels. Again, only works as long as it's used. The take-home point is women require higher doses of finasteride. They need 2.5, sometimes even 5. I usually start women at 2.5. Dutasteride dose is the same across the board. It's 0.5. And in any woman who's like postmenopausal, I have her on dutasteride because it's just a better drug. Can't be used in pregnancy or breastfeeding. Sexual dysfunction is the big one that comes up. It's reported in 1 to 4% of users ish. Like there's not solid numbers on this. It is something that I counsel on. Sometimes it talks people out of it. Sometimes it doesn't. There is a black box warning for high-grade prostate cancers on it. Overall, there are fewer prostate cancers, but it does lower the PSA. And so I always counsel them, tell your primary care that you're on this drug so that they know when you're evaluating your PSA what they're looking for. And this post-finasteride syndrome, which is all over the Reddit forums, these persistent, irreversible, so they don't stop when they stop the drug, side effects, including sexual side effects and this sort of long-term depression and suicidal ideation that people are linking with finasteride. It's more commonly seen in men who had sexual dysfunction. I treat a lot of women. I've never had a woman develop depression on it, but it's just something to know about. It's out there. I counsel on it. I don't think it's ever talked anybody out of it, but it's important to know.
And I'm assuming we're just implying dutasteride is kind of similar. And like you counsel people the exact same way. Like it's finasteride probably because it's used more, but dutasteride is probably.
Yes. Actually, there was just an article that came out that said the dutasteride effect might actually be slightly greater, but we're maybe not catching that as much because we're not using it so much in hair loss. We're using it more in patients with prostate problems. And so maybe we're not catching that as much. So.
Yeah. And this is huge for us because we check PSAs frequently and it like cuts it in half. And so like, yeah, if people, I don't even think to ask like, hey, just want to make sure, are you taking this? So that's good to know. Sarah Stolte had another question about minoxidil. So she's just asking, are the tabs easy to cut into quarters?
Yes.
Okay.
So yeah, full disclosure, I take it. And it's super easy. And you just like throw them in a pill cutter and they're super easy. I have one patient bites them. So.
Okay.
All right.
And then, if we run out of time, we can breeze over this one because I want to make sure you get to the other cases that we're probably less familiar with. But I just want to talk about counseling in this situation. So MJ is a 26-year-old patient, presents for subjective hair loss. She's extremely bothered by this as she won't stop shedding her hair despite use of many over-the-counter agents like biotin, topical minoxidil, Nutrafol. We discussed this with her 1 month ago and checked basic lab work, including iron studies, which before this, that's pretty much all I ordered, which I will change that, which returned normal. So she's been watching social media and says she would like hormone testing. So I would love your opinion on how to walk people through that.
So this will be pretty quick. So the person who comes in with a normal head of hair, right? So Dr. Kessenbaum at KU pounded this into us all the time. So in order for us to visibly see hair loss, it requires 50% of your scalp hair to be gone. So if the patient says they're losing hair, believe them. Each decade of life, we have fewer active follicles. We already said, you know, a large majority of us are going to end up with hair loss. Do your hair pull test, grab about 40 hairs, give a gentle pull. If you get telogen hairs, work it up, you know, check their ferritin, check their TSH, check their vitamin D, maybe check their zinc. We don't know. Evaluate their nutrition. If they look like they have PCOS, go ahead and do a hormonal workup if you can. Like we said, it's kind of hard to do. You know, minimize the damaging hair practices like heat and chemicals. And you may want to consider sending them to derm for a scalp biopsy if they have tenderness or persistent itching, because lichen plantarfularis is an epidemic. I'm hoping we get to that case today. It's all over the place and it's very, very subtle at first. And I've seen people present with what I thought was like not really hair loss, very mild hair loss. And lo and behold, on their biopsy, they have inflammation and they have scarring hair loss and we need to act now. So it's sort of, hey, you know, do our due diligence. If in the end, sometimes just explaining to people like, look, 50 to 100 hairs is totally normal. And they're like, oh, that's like what's falling out. And they're like, okay, then I'm probably normal. Then that's fine. Also counseling, like you're 26 years old. A lot of the medications that we're going to use, if you ever feel like you want to have a child at some point, you're not going to be able to continue them. So this might not be the best time to address that. Those are all things that we have to consider. So case number 5 is a case that I put in. So this is a 20-year-old male. He had sudden onset of bald patches on his scalp and he had anxiety because he had a bad breakup. And he's in the process of moving out of his apartment that he shared with his partner. He suspects his partner might have been unfaithful. He's had a little bit of itching. His PCP started him on clonazepam last week because he's had so much anxiety related to this breakup. He doesn't take any other medicines. He's concerned he may lose all his hair and he may go bald, but he hasn't had any labs drawn yet. So how would I approach this patient? So same thing, you know, we have a little more information on this guy, right? But you're going to get up there and you're going to look at his scalp and you're going to see what you see. One thing I would absolutely be thinking if I saw this hair is get a syphilis test done on him. So don't ever forget about syphilis. I see syphilis not infrequently, and it causes patchy hair loss. And in someone who has a partner who may have had other partners, it's really important to take a sexual history and find out what's going on, because you will see syphilis and you will see it present like this. But this is a case of alopecia areata. So it's sudden onset, it's patchy, it's non-scarring. This is a beautiful picture of this little girl. You can still see her follicular ostia. You see those little hypopigmented areas within that hairless patch. Those are her ostia. So she doesn't have any hair there, but she's got hair follicles still that can happen. So she can regrow hair. So it's immune mediated. There's loss of immune privilege at the hair follicle. Normally the hair follicle is sort of away from your immune system, and here it attacks it. It does regrow. When it regrows, it's gray. That's important to counsel the patients on because, you know, particularly in young kids who can get this, they think they're going to have gray hair. And it affects other areas of the hair as well. So it can affect lashes, brows, body hair. I usually look inside their nose. I look inside their ears to see if they have hair remaining there, because that will sometimes give me clues as to what's going on. Important for you guys, if you see this, is check TSH and thyroid antibodies. This is associated with autoimmune thyroid disease. And so that's something, if they get to us and that hasn't been checked, that's something that we check. And again, take a good sexual history, obviously probably not in this child here, but in our patient who we presented, because syphilis can mimic alopecia areata. I'll never forget, as a resident, our faculty bringing us in, showing us this great case of alopecia areata, and lo and behold, the RPR was positive. So here it is affecting the beard and the lashes, and these patients can go completely bald. And there's a rapidly progressive form, which I just had a girl have last year, where they go from like total head of hair to this lady on the right within weeks. And so it is like critical that you get them in with us as soon as you can so that we can start therapy as soon as possible, because it can go really, really fast. So recommend referral to dermatology, just like I said, because they can lose their hair really fast. So things we do intralesional steroids. We actually inject into their scalp with Kenalog. We put them on systemic steroids. We should put them on dexamethasone. And then I brought this one in just because there are a couple of new drugs, which you guys probably have heard about, baricitinib and ritelasitinib, which are JAK inhibitors that we're using for patients with severe alopecia areata. Good drugs, but kind of scary. They all have black box warnings for serious infection, mortality, malignancy, see cardiac events and thrombosis. So we're choosing our patients carefully. But as I said, a lot of these patients want hair. I have a patient who, serious smoker, history of cardiac events, who's on one of these. We've talked about the fact that this could be really bad news, and she says she wants her hair. And so we have done informed consent. And then topical immunotherapy, which we're not really using anymore because we have these 2 other oral medications, where you would put something on to sort of distract the immune system so it stops attacking the hair.
Dr.
Okay.
Kugel has a really nice question about this. And she's just basically wondering if we're waiting for someone to get into dermatology, say it's going to take a week or 2, and it looks like it's progressing a little bit quicker than we're comfortable waiting that long for, should we be starting someone on systemic steroids in the interim?
Yeah, so we usually use dexamethasone, and usually it's 4 milligrams twice a week is our starting dose. And I think that that's not a bad thing. Just check those thyroids before. But yeah, get them on dexamethasone so that we can get things started. And then sort of, like I said, we can take it from there. But if it's rapidly progressive, time is hair. And like in that one particularly, it's very important to get them in as quickly as possible. That said, we have openings, so you can always send them to us. So here's my little plug for my practice.
Yeah, we have, and we do have someone saying, because like with our dermatology department, they weren't seeing hair loss for a while. And I'm not sure all the specifics behind that, but I think they were just overwhelmed. I wonder if they see this stuff. I just don't even know that. But I do wonder, so for the thyroid studies, you're talking about the antibodies. Is it TRAB, or are we checking a TPO? Are we doing both of them?
You're doing both of them.
Both
Yep.
of them. Okay. All right, cool.
Yep. So, what else? Any other questions there?
Is there any role for topical steroids in this?
So maybe. So the problem is the level of the inflammation. So if you do a biopsy of alopecia areata, the inflammation is at the bulb of the hair follicle. So it's really, really deep. And so when you put on a topical steroid, even a super potent topical steroid, your penetration is not great to that level. Do I put my patients on clobetasol solution on their scalp when they have alopecia areata? Yes. Is it maybe just something for them to do to keep them busy? Potentially. There's also some really good Japanese literature, which suggests that putting them on Allegra every day might help with regrowth. So I also put them on an Allegra every day just because it's a panic situation. Again, I don't know how much it helps. I think there's probably very little harm from a daily Allegra. And it gives the patient something to do so they feel like they're taking control of their disease and they have a role in helping themselves get better.
Sorry, gotcha. Thank you. And then is there one other question on this? So is there any kind of magic to dexamethasone in particular, or do you think this is a steroid kind of like prednisone would work this as well? Or?
Anything would work. Prednisone's fine. We just like Dex just because it's a little bit longer acting, so you don't have to dose it quite as often. So
Yeah.
Any other questions on this? Okay. So this is the case I really wanted to get to because this is the thing that I see a ton of. And when you read about it in the literature, they're going to say it's really rare and it's not. So this is a 64-year-old female. She presents with hair loss, itching, and tenderness of her scalp for the past several years. She thinks it's maybe more than 5 years. That's pretty common. Nobody can tell you exactly when it started. She sees thin areas at the front where she mostly notices it. So we know maybe not female pattern, right? She notices hair shedding in the sink when she brushes her hair. She washes her hair twice a week. She tried over-the-counter dandruff shampoo, which helps on the days she washes, but then by the time she washes again, then she's already itchy again. She tried Nutrafol. She saw the ad on Instagram. Her prescription medications are lisinopril, fluoxetine, and atorvastatin, and she's taken all of these medicines for at least the last 5 years. She's very concerned because she does not want to have alopecia. So again, you're counseling her like, you already have alopecia. It's going to be okay. We're going to figure out why it's happening, and we're going to see whether it's reversible or not. Okay. So this is lichen planopilaris or frontal fibrosing alopecia. There's also an occipital fibrosing alopecia variant that's been recently described. This is scarring hair loss, and this is hair loss where you need to act. And again, it's very common. So you have loss of the follicular ostia. So in this picture on the right, it's a great picture. You can see these lone hairs out there where there used to be hair, and it's just shiny white, looks like facial skin. In patients who are severely sun damaged, you'll actually see their sun damage stops, and then they've got all this shiny white stuff and these like sparse hairs going throughout. So there's erythema, there's usually redness of the scalp, there's perifollicular hyperkeratosis. So right around the follicle, you'll see a little bit of keratin, and then they've got these solitary hairs. And it's very often involving the lateral third of their eyebrow, and their eyebrows will get red and scaly as well. It's seen all over the scalp in the lichen planopilaris version, and then the frontal fibrosing alopecia is mostly at the front. And then, like I said, there's an occipital version as well. These patients are typically symptomatic. They talk about itch. So very often they get treated as seborrheic dermatitis before they get to me, because everybody thinks, oh, it's scaly and it's red and it's itchy and all these things. And so that's what it is. Once your hair's gone in this, it's gone forever. We don't know what causes it. Sunscreen's been suggested in the past because it was more commonly seen in women, but I see it in a lot of men. They just all think they have male pattern, and so we don't really worry about it too much. But this can be seen in conjunction with patterned alopecia as well. So a lot of these women are going to have already the normal 60% of white women and all of the other patients who have patterned alopecia, and then they have this on top of it. So this lateral third of the eyebrows, you can see in that picture there. And then the picture down in the corner shows that perifollicular scale. It's a really good picture of that perifollicular scale. So dermatology referral, this is pretty slowly progressive. So it's not as critical that you get them in as quickly as the alopecia areata patients. We do a lot of topical steroids. The inflammation in lichen planopilaris is at the middle part of the hair follicle. And so you can get a little better penetration to the level of the inflammation. But we'll do intralesional steroids. So we'll inject their scalps, dutasteride, finasteride, hydroxychloroquine, tetracycline. There's case reports of pioglitazone, methotrexate or mycophenolate for resistant disease. And then very often we're adding topical or oral minoxidil to these patients to help with the probable female pattern. There was a head-to-head study which showed that dutasteride was superior. But the most important thing is recognizing what this is so that we can counsel patients that, like, this is a scarring hair loss. We must treat if you want to keep the hairs that you have, and you are probably not going to regrow very many of your hairs. So what about hair growth supplements, right? So most of the hair growth supplements, Nutrafol included, contain large quantities of biotin. So it's really important to know that the FDA has issued a warning on biotin, particularly super high doses of biotin, because it interferes with all of our lab tests. So TSH, ferritin, B12 folate, testosterone, troponin, CA125, there's a bunch. The most important being cardiac troponin. So, and then basically every lecture I go to now says there's just a complete lack of evidence for biotin in patients who previously had a normal head of hair. If you have an inborn error of metabolism of biotin and you give that patient biotin, they get good hair. In a patient who had good hair until they were 30 and then their hair started falling out after they had kids, giving them a bunch of biotin isn't necessarily going to help. So I actually stop biotin in all of these patients and tell them, look, stop spending $80 a month on Nutrafol and let's give you minoxidil, which is like $3 a month, and give you something that actually works. So I'll do these real quick and then we can do just as many questions as you want. So, most important things to remember: time is hair, treatments long-term. It takes months to years to see your results. Stop the biotin. Topical minoxidil is great. It does work. They just have to use it. If you stop treatment, it's going to go back to where you were. Doing a basic lab work, but before you send them to us, can find some pretty easy to fix telogen effluvium, and they may not even need to see us. And if there's scarring, make sure you're referring them right away. All right.
So first of all, extremely enlightening. Like Sarah Solti was just like, yeah, she's pumped about this. I'm pumped about it. It's like so helpful. I am curious, this lichen planopilaris seems like something that we really, really need to have on our radar, which I had no idea what it was until you sent me these slides. The ketoconazole, is this something where it was applied and because of its anti-inflammatory effect, it reduces the inflammation, or is it because there's actually a like overlying fungal as well?
So ketoconazole is anti-inflammatory. The other interesting thing, some people will use it. I don't do it as much, but in patterned alopecia, any androgen-dependent alopecia, because there's potentially some anti-androgen effect. So that's why a lot of people are using ketoconazole shampoo.
Okay.
In that case. Okay.
How difficult is it for just like a general clinician to learn how to use a dermatoscope to be helpful with stuff like this?
So it's pretty hard. So
okay. Yeah, great.
I've been doing dermoscopy for 12 years and I still am on all these Instagram groups following dermoscopy all the time because I feel like I'm still not as good at it as I want to be. It's a hard skill. But I mean, I think there are some primary cares, particularly in rural areas, who don't have a lot of access to derm, who get very good at dermoscopy. It just really takes a lot of due diligence.
And so when you're saying scarring alopecia for this one, I mean, scarring that's not the hair follicle itself, that's the skin kind of
So-
where it's happening.
Correct. But then the
Okay.
hair follicle is obliterated by the scar. So the hair
Yeah.
follicle's gone. So if you do a biopsy of a burned out alopecia that's been a scarring alopecia, all you'll see is scar. You won't see a follicle left.
Okay. And with this lichen planopilaris, like, because we see with a lot of these types of alopecia, we have this like creep back of the hairline or more diffuse. But if you see like hairline kind of looks like it's creeping back, but then you have these like satellite hair follicles, our suspicion should go really
Your
high.
suspicion should be really, really high in that
Okay.
case.
Super helpful.
Yeah, and definitely for any, and it may not be LPP or FFA, it may be some other scarring alopecia, but like, oh yeah, that's probably scarring alopecia. That's probably something that needs to be referred on because, you know, we can maybe halt that process.
Okay.
So can I ask a question? If we go back to the pattern hair loss kind of situation, how much hair growth do you counsel that? Like, how much do they expect with these different modalities? Like, minoxidil, do you quote them a % hair regrowth or what? Can we talk a little bit more about that versus,
Sure.
we talked about the risk, I think, quite a bit, but as we
Yeah.
give them the full picture of what benefit they might see with that.
So I quote them as 0% regrowth. And it's very purposeful.
Stop it. Or we hope that's the best case scenario.
Yeah, I tell them my number one goal is that you keep the hairs that you have on your scalp today.
Okay.
If you regrow, that is bonus points for us. But there, particularly in pattern alopecia, although it's not a scarring alopecia, there is such a thing as like too far gone. And so sometimes they just aren't going to regrow a heck of a lot. And sometimes people surprise me and man, they grow a ton of hair. And so I never predict. I always set the expectation really low of like, okay, the goal is to keep your hair that you have. That is a realistic goal. If you regrow, that's great. If you're at the point where you're already needing a hairpiece, like the likelihood that I'm going to get you regrown to the point that you don't need a hairpiece is probably not great. And so maybe we don't want to bark up this tree and take on all of these risks if you're already wearing a wiglet and you're happy with it. So.
Yeah, that's helpful.
Mary Kaiser asks, if you have someone on topical minoxidil and you switch them to oral minoxidil, are you still counseling them on that shedding period?
Great question. So it happens sometimes and then other times not as much. So what I usually do is just have them like go pick up the prescription and then the day that they start it, they stop their topical minoxidil. And it goes either way. In my opinion, which is purely opinion, I don't think the shed's quite as bad, but you can still see a little bit more shed just because you're getting a little bit better systemic absorption and probably some follicles involved that weren't involved with your topical. So.
And then I want to go back to Dr. Polsak's question because she asked about dosing of spironolactone. And we
Yes.
talked about it as a diuretic effect with minoxidil, but I don't think we talked about it generally.
We
Is
did
it
not.
dose dependent? Do you put it on and leave it or do you escalate?
So you can escalate. So we use a ton of spironolactone because we use it both for acne and for hair loss. I historically have not used as much for hair loss because I didn't think it was very effective. Although this article, like I said, that just came out this week is suggesting that it's actually pretty effective, particularly when combined with topical minoxidil. So up to 200 milligrams a day. And I usually give it all in one dose. Over the age of 45 in acne, they were saying 65 in hair loss, but you should check a creatinine and a potassium after you do a dose escalation, just to make sure that there's nothing going on there. But up to 200. So most people for hair loss, you're probably going to need at least 100, 150 a day.
Okay. And then Dr. Stolte asks a really nice question. She asks, is there any place that helps people if they're interested in getting a hairpiece? Is there any place around Kansas City that you send people to? So
there is a place. It is in, I may have to get back to you on this because I don't want to give you the wrong thing, but I think it's in out at 119th and Row in that complex where Chipotle is. And I think that's the place that some of my patients have gone and been very happy with getting hair pieces.
Cool. Anyone else? Okay. Enlightening, like amazing. So, I mean, so for full transparency, Dr. Stolte reached out to Dr. Chain and like Dr. Chain has been so amazing and like making this as high yield as humanly possible for us. Like we can't thank you enough for coming. Like this has been exceptional.
So, well, good. Well, and if there are follow-up questions, let me know. I'm sure I missed things and hopefully didn't make it too confusing or too fast. So,
yeah, as great as possible. Thank you so much. Thanks everyone.
All right. Thank you.
Bye.